Next up, as you can see from the slide deck, is Jen Brazeau, and she's just getting her mic clipped. Whenever you're ready, Jen, you can take it away.
Right. Okay, that's working. So, hi everyone. For those of you I've not met before, my name is Jennifer Brazeau. My practicum experience was a little different than most of yours, as I completed mine by distance. I had the pleasure of working with Dr. Nathan Lachowski and focused my practicum on his and his colleagues' research on hepatitis C in gay, bisexual, and other men who have sex with men in Vancouver. As my practicum was a little unconventional, I'll break down what I produced over my 450 hours. There were two main outcomes for this project. First, I contributed to a manuscript, and then I used this information in addition to the literature to create a knowledge translation tool. For the manuscript, I first conducted background research on Hep C and HIV. I then focused on improving my understanding of academic writing. For the manuscript, I was to evaluate the data, present information in tables, and provide a discussion on key findings. The document then underwent numerous revisions, as our goal is to submit the manuscript to the Journal of AIDS. The second product, a knowledge translation tool, disseminates information to the public and took form of a fact sheet. Not having made a knowledge translation tool before, researching the methods, the models, and theories was the next step. I then compiled the information and drafted the document. Community partners were then consulted, and they gave feedback, and we produced a final knowledge translation tool. The outcome of my practicum were primarily the manuscript and the knowledge translation tool, but in addition, the experience allowed me to build relationships with organizations and improve my networking skills. Before I go into too much depth about what I did, I'd like to give some background information on my topic. Hepatitis C is one of the leading causes of liver disease in the world. Hep C is most commonly passed through blood-to-blood transmission, and having HIV further increases one's susceptibility to acquiring Hep C. While rates have been decreasing overall in Canada, the rates for gay, bisexual, and other men who have sex with men in a population are closer to 5 times in prevalence. Blood-to-blood transmission is still the most common method of getting HCV and can occur through IV drug use. Sharing drug equipment may also be a method of transmission, as according to some past studies, nasal secretions have been found to contain the Hep C virus. Lastly, there is increasing evidence for sexual transmission in HIV-positive, gay, bisexual, and other men who have sex with men, as it can occasionally be found in semen. With respect to Vancouver, we found 2% of HIV-negative men and 28% of HIV-positive men were found with HCV. The main outcome of my practicum was the creation of the manuscript that would later be submitted for publication. The paper evaluates the results of the Momentum study, which was a 3-year study investigating Hep C in Vancouver gay, bisexual, and other men who have sex with men. The study utilized respondent-driven sampling, which is participants are recruited by other participants. The recruited men were then tested at baseline for both HCV and HIV, which made up our prevalent cases. Those who were not HCV positive were then went for a follow-up where they were tested again for HCV. Those who then became HCV positive were our incident cases. The study results found an associated risk with indigenous ethnicity, illicit drug use, and escort work in both HIV positive and HIV negative men. However, when accounting for other variables, IV drug use was the only drug significant at a multivariate level. Prevalent HIV positive, gay, bi, and other men who have sex with men had an additional risk if they partook in recent condomless anal sex with a partner of unknown serostatus. As for incident cases, all men were HIV positive, gay, and were more likely to be crystal methamphetamine users. Interestingly, though, we did not find an association in our incident cases with IV drug use. The manuscript is still currently undergoing revisions and will be submitted to JADES. A knowledge translation tool was then created with this information for the general public. In order to do so, we partnered with local HCV organizations to ensure that this material would be relevant to our population. 3 organizations were contacted: YouthCo, which is based out of Vancouver, Hep C BC, and Pacific Hep C, which focus on the province-wide. 3 other organizations were found: the Healing Our Spirits BC Aboriginal HIV/AIDS Society, Chimamuk, and Fraser Regional Aboriginal Friendship Center. However, they all focus on Aboriginal men's health, and as this is a generic fact sheet, it was not, I did not find that this would be appropriate and culturally relevant for those organizations. As some of you may not have created knowledge translation tools in the past, I would like to give a quick overview to the knowledge translation process and the models that were used. According to the Canadian Institute of Health Research, knowledge translation is the process of utilizing information from research and applying it in a meaningful way. They further explain 4 main categories to apply knowledge translation: synthesis, dissemination, exchange, and ethically sound application of knowledge. Synthesis involves interpreting research findings in the broader context of the field. Dissemination involves identifying a target audience and how to convey the message. Exchange is the dialogue with partners and those who will use the tool. And ethically sound application ensures that everything is done respectfully. All of these elements were kept in mind in creating the fact sheet. In addition to this, specific models guide the process. With regards to health promotion, 2 models are applicable: the readiness to change model and the social influences theory. However, the social influences theory was not well suited, as it focuses primarily on the impact of the social group and was more geared toward medical approaches and practitioners. The readiness to change model is best suited to this situation as it focuses on the steps to changing individuals' behavior. Here's a quick overview of the readiness to change model, where there are 2 main components to the tool. First, we have the stages of our population, which is pre-contemplation, contemplation, preparation, action, maintenance, and termination. And the second is the processes, which explain how to move from each step and how the change is facilitated. In order to ensure that no material was missed, a literature review was conducted. A search of PubMed and Medline returned 8 articles, all of which were redundant to findings either from the World Health Organization or from our study. The World Health Organization website was used to research the most up-to-date information on treatment, risk factors, and treatment, transmission, and risk factors. And this is the knowledge translation tool that was presented to the community partners. YouthCo was particularly helpful and gave us feedback on word choice and layout. And we continued to make changes until we found that it best suited our needs. While there have been an abundance of positive experiences and strengths that have come from this practicum, there are a few limitations. A limitation relating to the use of the readiness to change model for this tool was that we did not have information regarding the stages for the men. Not knowing this information made the process more difficult, as some of the information may be redundant to what they already know or may not address where they're lacking information. Second, we found Indigenous ethnicity as a risk factor for HCV. However, we're not sure specifically which behaviors are causing this increase. The question is, what determinants do Indigenous men face disproportionately that are resulting in this outcome? This is something that we don't yet know. The fact sheet has also not yet been distributed and cannot until the manuscript is published, which means that no evaluation regarding its effect can be done. With this in mind, there could be future changes that would improve the tool, which we might have missed. Lastly, due to the nature of this practicum, I missed the office experience and had limited practice with policy analysis. And a special thank you to Dr. Nathan Lachowski, who agreed to supervise my practicum by distance. I would also like to acknowledge the HCV organizations for their feedback and interest in being part of this process. Lastly, a thank you to the School of Public Health and Social Policy for this opportunity. Thank you.
Whew, another really rich practicum experience. Nate put you through your paces on that one. So, questions for Jen? Questions about Hep C, questions about knowledge translation? Well, I'll ask one while people are thinking. So I guess it's the tension between what you have in terms of information and what theory tells you would be best practice in terms of developing the knowledge translation tool. Do you want to elaborate a little bit on some of the missing pieces that it would have been nice to have?
So let's see if I can go back. Yeah, so what was particularly useful is that for each of the stages, they'll explain where people are, where the population is located, and whether or not they're actually looking to make a change. So, for example, pre-contemplation means that your population at the time is not at all considering making a change to whatever habit you're trying to address. Contemplation is that they're planning to do it in the future, but not within the 6 months. And then preparation is within 6 months. So this would all make a difference in that if you're located at a preparation stage, you'd be more likely to be looking for services to making that change, while if you're in pre-contemplation, you're more looking for, or your best chance is to target them with more information as to why they should make the change. So by not knowing exactly where the demographic falls, it's hard to make a fact sheet and know exactly what they would need out of that, whereas depending on which stage they're at, they would need different information to help facilitate to the next step to change in their habits.
So because people wouldn't have been able to see it because it's pretty tiny when you see it on the screen, what did you end up doing? A mishmash of all of those things, or did you focus on one particular stage?
Yeah, I tried to take as much as I could, anything so it would be applicable to everyone. So there is, let's go back forward. Yeah. So here I have generic, just facts to more address for people who don't know anything, and then trying to relate it more to Vancouver and why this is an issue they should be concerned. And then for those who already know a little bit, this is new information that is just coming out. And then to help move the process forward, to tell people to get tested, and then these are the organizations that we worked with that have the most information on Hep C for them.
Great, thanks. Any other questions? Oh, okay, I get to do my walking. Yay!
I'm just wondering how you incorporated, I'm assuming, so just because I've worked in the Ministry of Health with some of the syphilis stuff, and confidentiality is such a huge factor in this, and it's a barrier to why people actually go and get tested or seek out further information. So I'm wondering if that was a factor that you incorporated in the model to ensure that people can remain, or they can approach it in a way that's best suited for them, maybe not in the healthcare system, but through online models that would allow them to assess their risk or assess whether they may be infected themselves, and then to seek help at that point?
That's a good question. That's actually really interesting. I haven't overly considered that. The best I thought of with that was approaching, just having the organizations available. I know that the organizations are pretty great with what they do, but I haven't overly considered the confidentiality aspect of that. That's good.
Any other questions? Seeing none, we will say thank you to Jen. Excellent presentation.